We are live now, ma'am.
Thank you. A very warm welcome from the southern end of India. It's so wonderful to welcome you all for our Obstetric and Gynecology of Southern India's OGSSI live webinar on sexual medicine. Without much delay, let me go on to the Tamil Thai Valse. Chitrakala, please play.
Great, it was very nice clip. Good.
Sir, this is our version of the anthem of the sing in the Tamil Nadu, sir.
Tamil Thai was too. Great.
I request Dr. Geeta Lakshmi to read the OGSSI prayer. Is Dr. Geeta Lakshmi here?
Yes, yes, ma, I'm here. A very good evening to everybody. It gives me an immense pleasure as a joint secretary to be a part of this webinar. And anything to start with, it always needs the blessings of the Almighty. So I go with the OGSSI prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you, God.
I request you all to join us for this virtual lighting of the lamp. Thank you. Now, without much delay, I request Jairani Madam to welcome our chief guest, Dr. Ajay Mane, and our guests of honor. Over to you, Jairani Madam.
Thank you, Krishna. Respected chief guest, Dr. Ajay Mane, sir. The guest of honors, Dr. Vidya Topi, Dr. Revati Janagram, ma'am. Dr. Neeraj Jadhav, and the senior sexologist of India, Dr. Narayan Reddy sir, and the first great women sexologist from Bangalore, Dr. Padmini Prasad madam, the great sexologist of North Indian, Dr. Sanjay Deshpande sir, Ragini madam, and all the senior faculties here. We welcome you all for this wonderful webinar on a practical approach to the women's sexual health. As pointed out by all the senior faculties here, we know that sexual medicine still is a taboo in the society, both with the practitioners as well as for the public. To clear this and to make this into a real scientific approach, we have the senior doyens here. And in this webinar, we'll be talking on the various practical approach for the sexual medicine for the practitioners, how to approach it practically from the point of women's health. So for this, we have the senior faculties here who have come over here, and it's my great pleasure and honor to welcome the chief guest for this webinar, Dr. Ajay Mane sir, who is the right person for this forum, because sir has been the wonderful committee chairperson of the FOXI Sexual Health Medicine between 2014 and 16. And he's the present vice president elect of FOXI. And he's the medical legal consultant over 18 years, which he has been doing very philanthropically for free of cost, which is a real amazing fact, as a great practitioner who has a great wisdom for the medical legal aspect, which is a very much need of the hour. And he has been the chairperson of the Adolescent Sexual Health Committee of the MOX and the past president of Aurangabad OBGYN Society. And he is a trainer of the FOXI Adolescent Health Committee and a health advisor for the Sports Authority of India. And he has been a chartered president of the Rotary Club of the Aurangabad. And we have the great pride to have you, sir, as a very apt person to inaugurate and to make this webinar open to the delegates. So we welcome you, sir, and may have your kind words of wisdom, sir.
Thank you, respected Jayarani madam. Though she is my very good friend, she is senior to me, so I always call her respected Jayarani ma'am. Thank you very much for giving me the honor. Basically, I'm not that great. You uttered, you have given great words for me. Thank you. So respected Narayan Reddy sir, respected Kundavi ma'am, and my colleague Neeraj bhai, my senior advisor Dr. Vidya Tobe ma'am and Revati ma'am. So and Dr. Krishna, then Padmini Prasad madam, I'm very happy to see after a long time, and Uma Devi ma'am is also there. So basically, as correctly said by Jayarani ma'am, we are not that eager to speak about the sexual problems, though maybe from male, from female. But since these four chairpersons, first chairperson was Shantanu, second was me, third was Tandon ma'am, and now Neeraj bhai. Neeraj bhai has taken this committee to the topmost level of all the committees. And this is creditable, Neeraj. So we appreciate your efforts. And Jayarani ma'am is also supporting you since a long time. So I convey my best wishes for her future endeavor. So best luck, ma'am, for your future endeavor. And we always support you. And today's great speakers like Narayan Reddy sir and Ragini ma'am, Padmini Prasad ma'am is also there. Sanjay Deshpande, Poonam Mishra ji, Riti Jindal, Rashmi Patel, and Tripti ji. And the topics. Today, I'm very happy to see the topics. They are not theoretical. They are very much practical approach. And we need that because routine obstetrician and gynecologists do not know how to approach the patient, how to ask the patient, how to make her open to tell her problems. Because see, women, they are in trouble because of this shyness. They don't open. The CA breast was also increasing due to this ignorance and non-telling tendencies. No, this is routine chalta hai. This is the tendency. But women are nowadays opening, and we should help them. So this is a very good topic today. I congratulate Jayarani madam and her team for taking this task. All the best from my side, and we are always with you, ma'am. Thank you. Thank you very much for calling me here. Best luck.
Thank you, madam. Thank you, sir. Thank you. Thank you so much for your kind words. And really, your words are inspirational. And we look forward for working all with the FOXI to bring this sexual medicine, which is a very much need of the practitioners for all the gynecologists, because we deal with the organs of sexual functioning. That is, we deal with the vagina, we deal with the vulva, everything is our source. So we are really have to know about everything, which is the main thing for any practicing gynecologist. In that way, we really salute your efforts to start the sexual medicine committee as the second senior person to start on this, sir. Thank you so much for joining us, sir. And thank you for your blessing, sir. And I have the great pleasure and honor to welcome Dr. Vidya Tobe. Madam is the guest of honor of today. Madam, who is the president of the Kasoga. She is the professor of and unit of head of department of OBGYN of Al-Amin Medical College, Bijapur. And she is the dynamic chairperson of the Food and Drugs Medical Surgical Equipment Committee between 2018 and 20. Madam has achieved the FOXI Champion Award in 2019 and she was the ICOG Governing Council member between 21 and 23. And she has got the Best Committee of the Foxy Award of Dr. Mehru Dara Hanosita 2020. And she has been doing a lot of work in Jogi as a national corresponding editor. And she is the organizing person of the Kasoga 2016. And it is a real appreciating effect to start a federation with your dynamicity, madam. That shows a real your way of getting everything united to bring it as a federation. And she has been the president of the Bijapur Society 2009 and the secretary between 2007. And she had a lot of publications in various books and contributed to the Foxy Focus and speaker in national and international conferences. And she has conducted a lot of workshops and awareness program. Madam, we really have the honor to have you as the guest of honor for this webinar. Over to you, ma'am, for your felicitation.
Thank you, Dr. Jairani, for those kind words and introduction. Really, it is an honor for me to share this platform with Dr. Revati Madam, as well as Dr. Padmini Prasad and all the speakers. I must congratulate again Dr. Neeraj. He is doing a very wonderful work. And Dr. Ajay Mane, Dr. Ajay Mane is very close, like a brother for me. And we have done so many work in Foxy together. Moreover, I still remember Ajay Mane's Ahmedabad, his concluding workshop. It was full. And all the workshops were empty and his workshop was full. So always, whenever we talk of sexual health, we talk of positive and respectful approach to sexuality, and it is the least discussed. I'm in a medical college, and I don't think whenever they take the sexual history, they are very, very hesitant, our postgraduates. So it comes to my mind that they should have some positive experiences about means how to take a history, how to ask the patient, and whenever about the partners or practices or any past history of sexually transmitted diseases, about the protection or any prevention and any reproductive practices. So they are very hesitant, my medical students, my postgraduates. So I think this practical approach, what you have brought in today with so many stalwarts, so many speakers, our own Dr. Padmini Prasad, who is a stalwart, and really she is very good in this subject. She is really, I must say that she has brought this in Karnataka to a major platform, and she has last year also she did very good programs. So I appreciate your efforts, and really thank you, Jairani, to bring me as a guest of honor. I am going to listen this all topics carefully, and I want these to be practically means imbibed in our postgraduates also. So thank you again, and thank you, OGSSI, as well as all the speakers. I must say that this is going to rock this webinar. Thank you very much.
Thank you, madam. Thank you so much for your kind words and kind felicitations. And we really will go ahead with your inspiration and do the best in this committee, ma'am. Thank you so much, ma'am. And I have the great pleasure, pride, and honor to introduce my mentor, Madam Dr. Revati Janagiraman, who is the president of TNFOG and who was a past dynamic vice president of Foxy South Zone in 2016. Madam is my mentor, my guide, all my OG practice start with Madam's wisdom. She has taught me in the undergraduate level, may help me to get all the laurels of the OBGYN, and she is the one who created an interest for me more in the OBGYN. Thank you, madam. Thank you so much. And madam has so many. She has, she has been a president of many society, like founder secretary of the Madurai OBGYN Society. Madam is the past president, vice president of Foxy, and she's the present IMS Madurai chapter president. Over to you, madam, for your kind words of felicitation for this webinar. Thank you for joining us, ma'am.
Thank you, Jairani, for your kind words. And it's my pleasure to be part of this very interesting program. This area of sexual health in women is very rarely touched upon. And only very few, like Dr. Ajay Mane, Dr. Neeraj, and Dr. Jairani are able to handle this topic very nicely. And I used to appreciate Dr. Jairani for taking great efforts in organizing many sexual health programs not only for doctors, but also for public, especially in Tamil Nadu. And I'm proud to say that she is my student. And she's also committee chair of sexual health medicine in TNFOG. And I wish her success in the coming election also. And the topics chosen today are really very, very practical. As Dr. Ajay Mane said, we know everything theoretically, and it is very nice to talk about it as in lectures and other things. But when it comes into the consulting room, what words we have to use, how to express it to the patient in a very nice, it's really a delicate situation. And the topics chosen here are really very practical. And I am sure every practicing gynecologist should attend it so that they can learn how to approach this problem gently, so that ultimately we reach the success in getting the outcome also. I wish this webinar a grand success. Thank you, Jairani, once again. Thank you.
Thank you, madam. Thank you for your nice words, and thank you for your inspirational talk, and thank you so much. And I have the great pleasure and honor to welcome the guest of honor, Dr. Neeraj, who has made a lot of wonderful, very great, successful work for the past 3 years in the FOGSI Sexual Health Medicine Committee. He has been doing a very dynamic work to bring about a lot of awareness for the doctors all over the country with his various webinars, various knowledge, and various knowledge-packed symposiums which he has conducted to all the practitioners all over the country. We really salute, sir, for your work you have done in the Sexual Medicine Committee in the FOGSI. And he was Vice President of Rajkot Menopause Society 2022, and he's the West Zone Coordinator of the FOGSI Adolescent Committee. And he was a Joint Secretary of the OBGYN Society of Rajkot between 2011 and 13.
Okay,
and so over to you, Dr. Neeraj, for your words of wisdom.
Thank you, Dr. Jairani, for inviting me this wonderful webinar by OGSSI. Whenever I see any webinar when they talk about the sexual health, it makes me extremely happy. Why? Because as a gynecologist, we have to deal with the SHRH, that is sexual health and reproductive health. But somehow we have forgotten about the sexual health. We are only concentrating on the reproductive health. So from the Sexual Medicine Committee, FOGSI, we have tried lots of to sensitize all the gynecologists across the India to make them sensitize about this issue of the sexual health, and so that they can comfortably deal with the sexual health problem. Why? Because gynec is a first line of contact with our patient. They are so much comfortable with us to talk about any problem. So even they can share their sexual problem with us. So we as a gynecologist have a much more role to play when it comes to sexual health issue. There are some of the issues why we are not taking sexual medicine or sexual health as seriously, because we have a serious time constraint. We have so much busy OPD, and sexual health, we all know it takes lots of time. It takes a lot of time to deal with the problem, to take the history, to evaluate this patient is a very time-consuming affair. So that's one of the reasons is that also we are not that comfortable. We are not this subject in our medical school. So that's why we are lacking the confidence when we are dealing with the patient of the sexual problem. But now things are changing. Few days back only, 2 days back only, we have an ICOG certificate course. And believe me, there are more than 1,400 delegates who attended this course. So it was a first of its kind in the history of ICOG where so many delegates attended this course. So there is a need. And with such webinar, I'm sure more and more gynecologists will become aware and they become more confident in managing problem of the sexual health. So I must congratulate you for doing this series on sexual health. And I can see lots of work done in the other parts, like Dr. Padmini Madam is doing in the Kasoga, Dr. Madan Gamble is doing in the Maharashtra. So we all are doing our part, and definitely scenario is changing, and I'm sure it will help our patient a lot. So on that note, I thank you to inviting me in this webinar, and I must congratulate you to think about this subject. And I'm sure that you will continue this journey on the sensitizing our gynecologists on the issue of the sexual health. So thank you, Dr. Jayarani.
Thank you, sir. Thank you for your nice words, and thank you that we all should work together to make this forum a bigger one, a wider one, and make with good knowledge, good sharing of their experiences, expertise of all the seniors in this field. So we got most of the doyens here to talk on this, and I really look forward of working with all the forums all over the country to make this a very, very interesting platform for all of us to work with comfort, work with ease, and work with knowledge. Thank you for joining us and sharing your expertise and sharing your felicitations, sir. Thank you so much. And over to Krishna. Thank you. I once again thank all the chief guests, our guest of honor, for all of us, for all of you being here with your wonderful presence to share your words of wisdom to all of us here. And thank you so much. Over to Krishna.
Thank you, madam. Thank you for your kind words of welcome. And I extend my welcome to all of you. Everyone we meet is either a teacher or a mirror. The answer to this I will give you at the end of the webinar. With this, I say sexuality is a human instinct as natural as hunger or thirst. Now we come to the first session. We don't have a PowerPoint. It is a dialogue. I just recently read somewhere, we always listen to answer. Now, this is an opportunity for us to listen, just to listen to whatever we can and in this thing. With this, I invite Madam and Sir, Dr. Narayan Reddy. Sir is a person who needs no introduction. He's a man who's revolutionized sexual medicine in Tamil Nadu, especially in the South, where it's still a taboo in many of the places. Sir, thank you so much for joining us and enlightening us for this wonderful seminar. And Jayarani Madam is a person I will not go through. Her resume is very large. So if I read both their resumes, it's going to take a lot of time. So without much thing, I hope we will listen to the questions and answers, how to deal with our patients that come into our OPD. Over to you, sir.
Thank you, Krishna. Thank you so much for the kind words. And we are now here to talk on a very important aspect of sexual medicine or sexual health, which is an unconsummated marriage, where there is both the sexuality as well as the relationships comes into a role, which almost may be a very basic for the reproduction also. So the unconsummated marriage, this is not a rare thing. Sometimes we may wonder how it can happen, how the consummation will not happen. People may think, but still it has been prevalent so much among the young couple, or even a couple who have been married for years and years together, till they come with an unconsummation. So it is so common. The really prevalence, when you look into the data, there is no proper data, because many of the couple, they don't come out because of the shame or fear or guilt or what to do next. Everything will be a big question for them. And so they go into a form of a depression, anxiety, and all the gloom they have, whatever they had of a vision of the marriage, to have a happy married life with a good, happy sexual life, which is being affected by this unconsummation, which comes to their life as a real challenge and burden. And that is a very important part that any young couple go through, all the more nowadays with this improving. I mean, when there is an increasing the westernization as far as the IT sector, the working time, prolonged hours, everything makes them go for a lot of mental stress. And all through the media, they have a lot of trouble in the reality of proper consummation of the marriage. So it is a very complex one, though it looks very simple, but it's really a complex one. Still, when you ask elder women about the consummation, they'll be questioning, yes, is it happening? Yes, it's happening. In our practice, I'm seeing every day 3 or 4 patients. I think sir will be seeing every day 10 or 12, 15 patients. So much it is prevalent. Without knowing the exact prevalence, it has a lot of impact on the personal life of the couple. So when you come across a couple like this, gynecologist, because they go to the family physician or the gynecologist. So how we have to approach them? What are all the things that can happen with this? About everything about the consummation or the unconsummated marriage, we will be talking today. And we have the senior doyen here, Sir Dr. Narayan Reddy sir, to answer all my questions. regarding the unconsummation of this marriage. Sir, thank you so much for accepting my invite to be the person to answer for all our doubts and dilemmas about the unconsummation. So let me start with the first question to you, sir. Sir, how you define a consummation, or how you define an unconsummated marriage?
Dr. Jayarani, you have escaped. You are the questionnaire I got to answer. I used
Yes,
to
sir.
know Sam B.P. Moses of Madras Medical College. When he was the examiner for MD Internal Medicine, he used to read this James Hadley's novels. So the external examiner asked him, Doctor, you are reading a novel, you're not listening to the candidate answer. Dr. Moses said, the examiner need not know the answers. Examiner should know only to ask questions.
Yes, sir. That's so easy, sir.
Anyway, Dr. Jayarani, you asked a very good question. When genital sexual intercourse does not occur or did not occur in a marriage, then you can call it as an unconsummated marriage.
Yes, sir. So when a couple comes, how they will be explaining to you that whether their marriage is consummated, whether they will come out with a problem per se, or will they be telling something and you will come to a conclusion? So how you will be knowing that this couple are having an unconsummation?
The best of my knowledge, people do not come and say my marriage is not consummated. They'll only say my husband is not performing, or they say my wife is not allowing, or like that only. From that we have to infer. And in my opinion, of 40 years, 41 years, in my experience, people are willing to talk to somebody who can listen to them. Only thing, they must be comfortable and confident that you're going to listen to them. So most of the cases which came to me, basically, they come with the complaint where they are brought in by the elders saying that the couple have been married for so many months and my daughter has not conceived, or my daughter-in-law is not conceived. Do something. The focus is always on reproduction. Sometimes I wonder, what is that our society is doing? Our society puts undue pressure on youngsters to produce a child within 1 month after marriage. So ultimately, to me, it appears that the only goal of a marriage is to produce something, which is putting tremendous pressure. Now, what happens is a couple are trying to get to know each other in the beginning days of their marriage. If they don't have support of the family without interference, then they are under pressure to perform, which again will go against it, it will be counterproductive. That's how it happens. Usually, when people come to me, I have one advantage because they know that I'm a sexologist. So definitely they are open. They will not hold information back. But the question is, they may not immediately come and tell you the problem. They have to go in a roundabout manner. You have to have the patience, listen to them and extract the information, what you want to that. Then the man may say, Doctor, I'm not getting an erection. Or he may say that my wife is not permitting. I find there's a block there in my wife's vagina, something like that. And the husband may say, wife may say, my husband is not touching me. Husband is not making an effort to have sex with me, like that only. Then by asking that, if once you know the answers there, and you know intercourse has not taken place, then you're going to call it an unconsummated marriage.
Yeah. Yes, sir. As rightly pointed out, people come to me as a fertility specialist, they'll come with infertility. They would have done some 6 or 7 IUIs and they will ask me. And when I did a pervaginal examination, I can see that they haven't consummated the marriage. They will be definitely, she will be telling me very silently, we never do sex. That is how the women discloses. Sometimes they do more IVF and then come to us for another IVF. And then, of course, when we ask them very intimately, they may disclose that we never do sex at all. And very many times when you ask them whether you do sex here, they say, no, we haven't done like that. So that is a very important aspect, that they don't know the proper anatomy or proper way of a sex. which is a very important part of this unconsummation, which is happening in our part where they find that is no way to educate them properly, which is also a very important one. So as you rightly said, the man may disclose that he cannot do sex or he cannot do. Is man is the cause? If so, what, how you will ask the history and how you will ask him about his improper, I mean, whether they haven't done it properly, because men, you have to examine him, you have to ask, come out with a solution, or without a history, how we are going to ask him.
It's a good question, Dr. Jayarani. Before I answer that, let me tell you, I have clients whose marriage had not been consummated for more than 30 years, 27 years, 25 years, etc. The only way to overcome the family and societal pressure, I referred them to fertility specialist, and they got their children through either IUI or IVF, ET, whatever it is. Now, the problem is not a small one, it's quite a huge one, in my opinion. Now, when a couple come and you realize that the marriage has not been consummated, you have to first find out the problem lies with whom? With the man or with his wife, or with both sometimes. So that's how we have to proceed. Now we take, in general, there are psychogenic problems which prevent sexual intercourse. There are organic problems which prevent sexual intercourse. And once we come to that, let us say psychogenic, we have to talk on the part of the female, on the part of the male, and problems in relationship. Same thing happens when it comes to organogenic factors, on the part of the female, on the part of the male, and again, a combination of both. Now, what I sometimes realize, now this is a very debatable issue. Sometimes the wife may have a phobic fear of penetration, have a severe vaginismus. Husband may be asexual or a homosexual, so they don't bother to improve their sexual status. All that they want is have a child to shut the mouth of the parents and the society. When that comes, we are totally stuck. I mean, I personally feel we shouldn't meddle if they're comfortable with that status. That is up to them. But it produces distress for any one of the partners in the couple. Then I have to find out from which side the problem lies. The problem lies with only one partner or both the partners. That's how I am going to proceed.
Yeah, as you rightly pointed out, yes, sir, we have to look into as a couple, and many a times the vaginismus of the women may be reflected on the couple as an unconsummation. And definitely when we examine them, we ask the history that women, she will not allow even for a vaginal examination, and we know pretty well vaginismus is one of the cause. And for the man, it is the erectile dysfunction, which may be a cause or maybe an effect of the vaginismus. It could be any one of these two might be causing the unconsummation of this marriage. So I just want to ask you one question. So when they fail to do the consummation, as you said, they are in a distress. They are in a distress of, one is reproduction, and second about the marital relationship. So how their marriage will get affected, because you would have seen a lot of couple like this, and how they end up when they haven't have a consummation, they come for a fertility one. Another aspect of how they will be looking this unconsummation as a part of their relationship, how they look into it, sir, and how we can counsel them, how we can treat, how we can educate them about these things, sir.
Now, when a couple come to you, and when you realize the marriage has not been consummated, we have to now see what is their objective of the consultation. They just want to have some more child, or they also want to improve their marital relationship, or they're only interested in performing the intercourse. That's how we have to proceed further. Now, in my opinion, in general, this is my experience. I cannot say every other doctor will have the same experience. Whenever I get a couple, I'm not only talking about unconsummated, in any sexual problem, the women are more concerned about the relationship. The main complaint is my husband is not spending time with me, he's not sitting and talking with me, he doesn't spend time on foreplay, etc. The men are only focused on that penis. So I will only say the men become penis-centric, where the women become couple-centric. I would rather appreciate the women because they want to hold on to the relationship, improve the quality of the relationship. Somebody told me sex has got 3 dimensions, namely procreation, recreation, and relation. Now, today, luckily, procreation is under our control. One, we have family planning methods on one side. And then, as you know, you are being a fertility specialist, all the techniques available in ART. And recreation, if it is irresponsible, you also know the consequences. Most doctors fail to understand the importance of the relationship aspect. And that's what we really have to address when somebody comes to, even with a sexual problem or non-consummation of the marriage. So basically, unfortunately, I don't have time here and I didn't bring my PowerPoint. The method of taking questions. Now, the Western authorities are given formalized inventories, but I personally think they are not very useful in clinical practice in South Asian societies. Because 2 reasons. One, that they give the questionnaires when the client is waiting in the reception or a waiting room. And they have only one language for any country, by and large. Anybody can take it. In India, we have 121 different dialects. And I can't be printing everything and keeping. Even if I give that, they are not going to fill it up. Their ability to understand is again a problematic thing. Best is we have to ask questions. Prakash Kothare developed a very good method of questioning in South Asian society, which I added there. I added one more thing called satisfaction. Are you satisfied even after you rectify, resolve the problem? You have to ask the couple, the man and the woman, are you satisfied? Then you get the real clue. What is that they're expecting from you? But if the marriage is unconsummated, initial days, the pressure will be on the couple to produce a child. And even if they come to a sexologist, by second month, they'll run to fertility specialist.
Yes, sir. You're right, sir. So that happens for many of the couple. And many a times, interestingly, they come for the second baby also for the same method, not bothered about the sexual life at all. They'll be very happy with the child. The husband will be a very good friend of them and they will have been very intimate, very much into the intimacy, but they never have a proper sex. And they are also start living with that lifelong. That is a very interesting part of many of the couples whom I have met and we have treated also. So I just want to ask.
Yes, one more thing,
yes,
one more. I think the parents must take the blame equally. I'll give you one case history. At Apollo, a couple went to the gynecologist for having ART procedure. The gynecologist picked up the marriage was not consummated even after 8 years. So she referred the couple to me. So when I asked the man, how often we make an attempt, the man got very angry with me because he's an IIT professor. So why are you wasting my time, doctor? I said, look here, this is my profession and this is my job to ask. No, I came here to produce a child, not to talk about my sexual life. And then he got very angry. He said, I cannot waste my time on these things. You know, is the word highly qualified professor from IIT said, I will not waste my time on these things. The woman was in tears. Subsequently, next year, the woman came along. Then I asked him, why are you still sticking on to this marriage if this is the attitude husband? I'm not trying to separate them. But she said, sir, what can I do? I told this to my parents. My parents said, you don't make an issue. He's a nice man. He's earning well, highly respected man. Some more get a child, your life will be okay. This is the attitude of many of the parents. They somehow think that a child in the couple will resolve the issue. In Tamil, they say, no, so this is not going to help. So the blame has to be taken by the parents also.
Yeah, you're right, sir. So that's what they're happening. But nowadays, the women are also getting liberated. They also want to have the life to live like with a good sexuality. That is a very important one which is upcoming. And many a times the women are nowadays, they are even going to the court because many of the divorces, almost 76% of divorces which is happening in the first year is mainly due to the sexual issues, which could be one reason is an unconsummation. And another one is the sexual violence. So these are the two important things they say as the cause for the divorces, which is happening in the family court when there is a divorce in the initial 1 year of life. That's what they say. So in this way, I would like to ask you why they are not coming out I mean, very openly. Sometimes the couple, they themselves never come out and even the family is not supporting. Is there anything, a legality? How the legality will take? Because this couple, if they blame them as an impotent a man, then he will be liable that she can get a divorce, which is legally acceptable. What is your opinion on the legality of the unconsummation of the marriage? Because if a couple comes and asks, see, doctor, this man is not doing sex, even if you treat him, he's not accepting, he's not cooperating. Can I get the divorce? You advise her a divorce and she's not willing because of the family. But if they're really willing, how it goes about it? What are the evidences that they can give? And if they ask, what as a gynecologist, what we are supposed to give to the legality for the court, which can accept and give them a proper separation?
I'll answer your question, Dr. Jayarani. Before that, I would like to contest the statistics given by the media and the High Court. Now, yes, people do also go for divorce because of non-consummation or husband's importance, whatever it is. But the numbers are more because the lawyers that tell the lady, give this reason, then you'll get divorced much easily. The lawyers twist it. So that's again a problematic issue. So I do not go by the statistics, but if you want to say, it's a fact that many marriages which are not unconsummated ultimately will end up in the family court. Now, coming back to the question of evidence, you cannot give an evidence. There is no evidence because none of us are going to be in the bedroom with the couple, or we cannot have a CCTV camera in the bedroom. So it's very, very difficult. All that we can do is examine the client, find out whether physically everything is right or wrong, or a obvious psychopathology is there or not, obvious. That's all we can say. But the point is, let us take a couple where the man is a homosexual. When you do the test, everything will be normal. But can I say he's potent? I cannot. But there is no way I can certify him to be potent or say he's impotent. It's very, very unfortunate that even today, our medical college forensic department and urology, they make the terrible blunder. They are following the old textbook of forensic medicine when they do a penile Doppler with the injection and certify somebody is potent or not. I've been contesting. I told this to many of the High Court judges, but their question is, doctor, I agree. I understand scientifically what you're saying is correct. But to me, a case has come in the court. I have to make a decision. Tell me by which means I can to take a decision. I am stuck. Now,
Yeah.
I hope that some of you must have read in paper, Dr. Indrajit Khandekar, who is a forensic specialist from Wardha. Sanjay must be knowing him there because Wardha is near Nagpur. He is the one who fought and got the ban on virginity test, two-finger test. He recently gave to National Medical Commission in writing and to the High Court also, and the university there, Maharashtra University of Health Sciences, that the potency certificate given by doctors in the nowadays is impracticable and it should be avoided. So as far as I'm concerned, when the court asked me to decide, I said, I've examined so-and-so, the physical findings, the laboratory findings, etc., history, and there is no physical abnormality which can come in the way of sexual intercourse, performing intercourse. That's all. It's very, very difficult for us.
Thank you, sir. Thank you. Thank you for highlighting all those things. So I would like to ask you, sir, if a couple come with an unconsummation, how you are going to approach them, how you are going to treat them?
First, I start with the history, as I mentioned. In sexual medicine, 75% of your data comes from adequate, proper, comprehensive history. The remaining only comes through lab and other things. history itself will tell what is the problem. Is it erectile dysfunction or extravaginal premature ejaculation, or is it vaginismus, phobic fear of penetration, etc., whatever it is. Number two, there may be problem in the coital postures and techniques. It is very unfortunate. I'm sorry if I'm taking your time, but it is very important for us to understand. People make the mistake that the male on top coital posture on the bed is the best thing. It is not so. Our elders in villages, their cots are very high. The woman has to lie, spread her thighs, come to nature's position, or she can rest her legs on the husband's shoulder, where the man will be standing. Then the penetration is much more easier. The position is comfortable. One, the line of vision where the vaginal opening is clear for the man. And number two, most men stand and walk, so their thigh muscles are stronger. But if they come on male on top, their forearms, elbows cannot help them out. So this is the best coital posture. Now I would jokingly say, the men do not know what they got. And how will they expect them to know what the wife has got? We never got an owner's manual when we were born. That's the problem. That's where you rightly said, good sex education before marriage goes a long, long way. Once you identify what the problem is it ED or is it premature extravaginal ejaculation, or it is vaginismus, phobic fear, whatever it is, sometimes there will be a deliberate avoidance of intercourse by one of the partners. I'll give you one or two examples. One example. Nowadays, as you rightly said, women are liberated. They are highly qualified engineers. They go to IT sectors and they earn a lot. They pick up friendship with their men, their colleagues there. Nothing wrong with that. All that. The parents are worried. The boy is out of their community. They don't want their daughters to pick up a relationship and marry somebody who do not belong to their caste, their community, or their religion. They forcibly make the boy or the girl to marry somebody within their community and all. So in such situation, the man or the woman will not attempt to have sex, but put the blame on the other partner. The man will say she is not cooperating. The woman will say husband is not doing. We do not know who is doing what. Only by circumstantial evidence you can come to it, but again you cannot prove it in the court of law.
Yes, sir, you're right, sir. As we come across with many of the unconsummated marriage, it would be the girl doesn't like the marriage or the boy doesn't like the marriage. That's the first one. So they don't want to have sex. Second is the common is the man is having an extreme premature ejaculation or an erectile dysfunction or a performance anxiety, which leads to their unconsummation. And for the women, it is a vaginismus and also lack of education about the anatomy and the position and how to have a vaginal penetration. It is the very common thing that we come across even with the educated, and we have seen many of the medical fraternity or the doctor couples who lands with an unconsummation marriage without knowing a proper way to have a performance. That's very, very important, as you rightly pointed out, that we doctor fraternities themselves, they don't know exactly how to perform a sex. So a proper sexuality education, it's not how to perform a sex, to know the anatomy, what is a erection, what is a penetration, what is a vagina, everything has to be taught properly as an age-wise comprehensive sexuality education, which will educate them, as you rightly pointed out. And second, as you rightly pointed out, we should have a proper premarital counseling, because many of the times the counseling which has been given to the girl is the sex, the first penetration will be painful. So that itself may make her go for a fear of penetration, and that will end up in a lot of problem. And for the boy, it is something that he has to perform on the first day of this wedding night. That makes him more for an anxiety, that keeps him go for a problem of performance anxiety. So all these things play a very important psychological role in this unconsummation to happen among the couple, as you rightly said. So I would like to give you a pearl of wisdom, how we are going to give them a proper premarital counseling. If they come to me or to any one of the gynecologists, my children are going to get married. If a mother comes and says, or a girl and a fiancé comes and says, what are the things that you want to educate them to avoid this unconsummation? And secondly, if they come with a vaginismus, what is the next step? Or if the couple is coming as a couple, will you check the women and also treat them together? These are the two things I want to ask you for our listeners.
The right thing you asked. First, I'll answer about the vaginismus. When you take the history itself, you realize there is going to be adductor spasm. That will give a very good clue about vaginismus. And I, being a male doctor, they permit me, in the presence of my lady secretary or lady psychologist, I have tried to examine them. But many times, I will not be able to perform a PV. And sometimes the women are willing, husbands are not willing, but their wife to be examined by a male doctor. So I refer them to the gynecologist. Fine, we get the information. And then we have to work on that. Coming back to premarital counseling, that's a very good idea and good concept. But the best thing will come only when the couple, as a couple, come to you for premarital counseling. Why? What happens is, if only one person comes to you, you advise them, they are knowledgeable, other partner is not knowledgeable, then there's going to be a problem. I have noticed this because there are about 8 or 9 young girls, psychology students who worked under me, got trained. They were knowledgeable. But unfortunately, on the so-called first night, they tried to guide their husbands and they got very angry. Oh, this girl knows so much. That means she must be loose character. So I tell my ladies, girl psychologists, that never open your mouth. Give the happiness to your husband, thinking that he knows everything rather than you. Unfortunately, male has got a very big ego. He is supposed to know everything. Women are more willing to accept that they do not know their problem, unlike men. That becomes a problem. Now, one thing which most of us are failing to pick up or understand, which we have to go back to Vatsayana's Kama Sutra. The ideal thing is the couple come to you, tell them, do not attempt genital sexual intercourse first 3 days or 1 week. The idea is, in an arranged marriage, they do not know each other well. So the first 3 days or 7 days, they have to spend time together, talking to each other, becoming comfortable with each other. Only when they become comfortable with each other, they should make an attempt to have genital intercourse. In fact, Vatsayana says that the couple will not sleep in the same bed. They have to lie separately. And he very clearly says, unless the one becomes comfortable, do not attempt intercourse. His words of wisdom, given by 300 to 400 AD, I have not come across by any Western authority or any of our sexologists in our so-called premarital counseling and sex education. We really have to fall back on Kama Sutra for many things.
You're right, sir. So as you rightly pointed out, there is no other ways of proper counseling to be given to the youngsters. But as you rightly pointed out, that we must have a forum to formulate a comprehensive ideas about the scientific background behind the proper counseling related to the unconsummation, which is a very important one, which can avoid such problem which is happening in the young couple. So I think you have given very many things. Yes, sir. Please, sir.
I have one question since you raised about that, for premarital counseling and all that. Since Foxy and Oxy, very huge organization, you have highly qualified doctors with you. If tomorrow your organization conducts a premarital counseling for to-be married couple, you can advertise, publicize it, and you do it in a hall where the to-be married couple come to you, and then you explain everything to them. Then that will go a long way, because parents are not going to do this. Healthcare workers will not do that. And Many professionals will not do that. But since I have noticed the Foxy and Oxy are most active in the field of sexual medicine. So I would request you to kindly take up this and start offering to the public premarital counseling free of cost. And you can advertise with your good officers in your clinics also that this program will be done on this day. And if you want to bring your children, you kindly bring them here. That will go a very long way.
That's really great, sir. Yes, sir. We will look into it and really we will formulate a proper system, as you rightly said, to make these issues well organized with Oxy and Foxy and all the societies, so that we'll make it as a whole nationwide program, as a position statement, which can give us very many people to get into it and get the problem of this unconsummation being an effect on the relationship, psychological stress, anxiety, depression, which happens in the married couple, can be avoided with a proper scientific way of counseling, sir. So thank you so much, sir, for your great words of wisdom.
As you rightly said, that is why in our custom, immediately after marriage, they don't have this function of Santi Muhurtam and all. They fix a date, wait for some time, and then only allow them to have that. This custom is very good to follow.
That's good, madam. Yes, you are right, madam. That is also very important, because they will come out of the stress of the wedding distress and all the other issues, get know each other, know about the society or the living conditions. That will help them more to relax and then start to live in the best way. And maybe the honeymoon period, that is also there for the other group of people to know each other. And all these things has to be made into the premarital counseling. What we are going to, as rightly said with her, we will definitely work on this issue and get this corrected, sir. Thank you so much for joining us, sir. Thank you so much for giving your very nice and very scientific content, which will be definitely beneficial for all the delegates who are there. Thank you, sir. Thank you so much. Over to Krishna.
Thank you. Madam, I would like to share, sir, like you pointed out, I hail from Kanyakumari district, sir. So we have an organization called Suraksha. So the government, our collector, has asked us to go to many colleges. And so we are doing it in girls' colleges already, sir. Especially a premarital counseling, because what we have seen with all the couples is, like you said, the parents also, and as well as they have a very short time they come to you for a divorce or things like that. So nowadays we are doing it as part of the college. The young girls from 22 to 21, they are being, we have at least started it on a district level, sir. We hope it will come everywhere soon. Thank you so much for that wonderful and a very practical section, sir.
I have a suggestion, doctors. Sorry, I'm taking your time.
Not at all.
See, I have noticed women's magazine like Femina in English, and you have Sananda and Bengali, Vanita and Malayalam, so many, so on, so on, so on. Now, they bring out wedding specials. What is that? About what type of clothes to wear, what type of jewelry they can wear, how to make up for the bride, etc., etc. In some towns like Hyderabad, you have wedding malls separately. All that you do, walk into that with a money bag, right from wedding cards to dresses to jewelry to everything there. And then they spend time on caterers, etc., etc. But if you, as being a gynecologist, being a woman, your organization can tell the magazine editor that you give us a chance, we will participate in the wedding special issue, and there you can bring out all these issues, and that would go a long way.
That's it. Thank you, sir. Yes, sir. Yes, thank you so much, sir. Thank you, sir. Thank you.
Thank you, sir. Now we come to the next session. Thank you so much for that informative session. Sexuality is a topic that has huge shifts in society. Attitudes towards different sexualities change, but the actual sexuality of women is something that is consistent and interesting. That is why we have so many people talking about it. With these words, we go to our next dialogue on pregnancy and sexuality. For this, we have none other than Padmini Madam, who is one of the first lady sexologists from Karnataka. Now, ma'am has a very large, she's the first woman, she has a very large this thing. I just let you read it. She's a chairperson of the Sexual Medicine and STD Committee, and she's a founder president of the Bharatvasi Charitable Foundation. Madam, and she has been, she's an author par excellence. And Madam, without much thing, I will let you speak to Sanjay Deshpande, sir, who's a past chairperson of the CSIP. He hails from Maharashtra. And sir has, again, his laurels are large and very, very this thing. He's from Nagpur. So this is going to be a very interesting conversation. We are going to listen to both of you. Over to you, Padmini madam. Please share your screen.
Okay. Before I share screen and 2 minutes of introduction, I'll give to the topic. So at the outset, I would like to thank you profusely for giving me this wonderful opportunity to be with you all for a great learning opportunity and exchange the ideas, and especially making this sexual health or the sexual medicine to be appreciated by all the professionals, especially the gynecologists. So I must congratulate Jairani and the team, OGSSI. And as a chairperson of Sexual Health Committee of Kasoga, I am participating here for this wonderful program. I welcome my co-speaker, Dr. Sanjay Deshpande, for this dialogue.
Thank you.
Okay, welcome. So just to give you a few examples, how important it is whenever you are talking about pregnancy and sexuality. Because as gynecologists, you know that each and every gynecologist will be handling the cases of pregnancy, childbirth, and how important it is to make sexual health or sexual history as a part of overall history, and how to advise the couple and how to answer their questions, because the female sexuality is a reality and the women are getting educated and they're thinking individuals and they're independent, and so many will come with lots of concerns and questions. And at the same time, still the sex is a taboo, and many have got their own attitudes, concerns about the sexuality during pregnancy. And there are so many cultural inhibitions which are always there. Recently, my maid servant came home crying, and I just asked her, what has happened? Why are you crying? No, it is about my daughter and son-in-law. My son-in-law has developed an extramarital relationship. The whole marriage has been disturbed. Because why? Then I asked her, just send them to me. I'll just have a talk with her. When they came to me, then I came to know that during pregnancy, they never had any sexual relationship. Post-delivery, she was within the mother's place for nearly 1 year. And for nearly 2 years, they did not have any sexual contact. Because even the husband was not allowed in her room also to stay with her or sleep with her. And so many of these attitudes in our culture. And the other case, one lady was repeatedly coming and getting admitted for recurrent APH, antepartum hemorrhage. She was coming all the time. She used to get admitted for 2 days. And then when we examined, we could make out that there is nothing. So then again, she went home. At around 8th month, then she begged me once when I was taking history, please don't send me home. Keep me here till I deliver. That is because the husband was having so much of interest in sex. He wouldn't allow her. Every day he wanted sexual relationship. Though she said that she is pregnant and having problem and sometimes she is developing bleeding, so he wouldn't listen. So the relationship problem, and if the husband is a drunkard, and what is their attitude, what is their social condition and the status. So to know all that, because sex is not a simple thing, so many things are acting on that. So the another case, when she was carrying twins, and I told her, because she was getting repeated contractions of the uterus, not to have sexual relationship. Then after 1 month, she came back with an inevitable abortion. I asked, what's the reason? What has happened? No, doctor, I told my husband not to have sexual relationship. And my mother-in-law told me, you should do all the housework so that you can deliver normally. and you should have sexual relationship so that there is normal delivery is possible. Our doctor may tell so many things, but this is all, we all had normal sexual relationship during pregnancy, and so nothing will happen. So she came back with abortion. So all these cases, they never had any counseling or advice regarding the sexual relationship during pregnancy. Because when a woman, when the couple comes, not all are highly educated. We have rural women, urban women. We have highly educated and less educated. We have rich and poor. Depending on their conditions and background, we should understand them. We should understand the concern. We should directly advise them regarding this. So for this, I welcome Dr. Sanjay Deshpande to discuss on certain issues, what are the changes that can happen during pregnancy, and what, as gynecologists, you should know, when you can advise the sexual relationship, when you should not advise sexual relationship, what changes they can make. So to discuss that, I have got a very wonderful person who is very knowledgeable and past chairperson of our CSCPI. So I will share my screen now.
Madam, could you? Thank you.
Yeah. This is our Kasoga. We have our, I'm happy to see Dr. Vidya Thobi, President Kasoga here, who is attending and who is blessing us for this webinar. And I thank all the concerned office bearers of Kasoga and giving me an opportunity to be the Sexual Health Committee chairperson. And I congratulate OGSSI again for this wonderful knowledge sharing session. So coming to this pregnancy and sexuality, a dialogue on approach to pregnancy and sexuality. Myself and Dr. Sanjay will be participating. Women's sexual function is a complex interplay of physical, emotional, and psychological factors between the couple or partners. Pregnancy is a very natural phase in a woman's life. Both pregnancy and sexuality are natural and normal phenomena of a woman's life. To be a mother is a natural instinct of every woman. Pregnancy or childbirth is not a disease. The couple need not be denied of sexual pleasure and happiness when pregnancy is devoid of any complications. Sexual relationship is part of quality of life. The woman and the couple will have plenty of questions regarding sexual activity during pregnancy. Changes in sexuality can be significant during pregnancy and in the postpartum period. So I would like to ask Dr. Sanjay, so as soon as a woman becomes pregnant, usually what are the normal advices that she gets, and what is that she does not get? Can you please explain to me?
Yes. Thank you, Dr. Padmini, for asking this very important question. But before answering this question directly, I can just say a few words about the psyche of Indian society. Now, what happens when a woman or a girl after marriage becomes pregnant? Everybody is so happy that the pregnancy becomes the most important thing for the life of that woman, her husband, her in-laws, her parents, everybody. Because in our society, it is always said by many sociologists that a girl or a woman gets importance only when she gets a child, only when she gets pregnant. So it becomes so socially prestigious also. It's not only the interaction between couple, partners, or their parents and family members, but the society as a whole. So understand that is the most precious thing happening to a woman, and especially when she is pregnant for the first time, in the first pregnancy. So everybody is after it. You all people, you are doing practice, infertility practice and ART and everything is done. You know how pressure on them about conceiving a child. So whenever she is conceived, then the marital relationship or relationship with the husband is taken a back seat. Usually, whatever you told in your the case with your maid servant's daughter, it's a reality. A woman is sent to home after around 7th month of pregnancy, and then she will come after her child is 6 months old. So this 8 months she is at her parents' house. Before that also, because nobody discusses. We even gynecologists also or obstetricians, I can say, they are so concerned about the safety and safety. What you can say, the best outcome of the pregnancy, that they also want that the pregnancy is the most precious thing. Other things are secondary, and because of that, we give more and more advices on our diet, sleep, days, travel, even puja part and all other things, but we'll never give her the advice regarding sexual matter. So whatever is more important, we don't give, because pregnancy is so vital, so important for that women and for that obstetrician also, because she has to take that woman safely for the successful outcome.
Yeah, you are very correct, Dr. Sanjay. So many cultural things and practices, attitudes we have. And because sex is a taboo topic, and also their couples are uncomfortable talking about these issues to the doctor. And doctors also think that it is not an issue to be discussed. So that is the main, either because they inadequate knowledge or how to go about it or what to do with the advice or how to advise them. We have those lot of problems. Yeah. So there are various changes, hormonal changes which occur during pregnancy. So these are all, you all know that there is a cocktail of hormones during pregnancy. Progesterone, which is responsible for physical and mental changes. Estrogen can affect sexual desire and function. Oxytocin can be released during orgasm, which can cause uterine contractions. Prolactin hormone, which is so with an increased level, it can affect the sexual desire. Dr. Sanjay, what are these physical and psychological changes which can happen to the woman during pregnancy?
Yeah, as during my first interaction, I said that pregnancy is so important, and these changes are more. Correct me if I'm wrong. In first delivery, during second delivery or second gravid, I think she may not be having that much stress. But for the first time becoming mother, a woman is more stressed. Maybe her self-esteem, I don't see that self-esteem may be decreased, because sometimes it may be increased also because she is becoming a mother. But definitely anxiety, fear, body image. Nowadays, women are more conscious about their body images during pregnancy. So some sort of inferiority complex may be there. Maybe working women are more stressed than the housewives or what you can say, homemakers. I should not utter now housewives, but they are homemakers. And definitely cultural differences are there, because in Maharashtra also we see that there are a lot of restriction on women when she becomes pregnant, that she should not do this type of work, that type of work, she should not go outside, she should have all this dupatta and the cotton on in her ears and everything. So, and regarding sexual problems, I said that first time when she is becoming pregnant, she's pregnant, she's afraid that sexual intercourse can lead to some sort of damage to her pregnancy. It may harm the fetus, that may be painful for her. So there are many things in her mind. And the same thing I can tell you in the minds of a husband also. So he also will not pressurize, mostly in the educated people. And the reason for this is that I think gynecologists should start, many of the big cities, they start consulting with the husband during all ANC visits. But that should be a routine. A husband or a father, future father, must be involved in all ANC visits of the wife.
Yeah. So there are various physical changes which can happen, the physical and psychological changes, which can have a bearing on the sexual relationship or sexuality. So you all know that during the 3 trimesters, the changes will happen, especially in the first trimester with nausea, vomiting, urinary frequency, urgency, back pain and other things. She is not very comfortable and not in a mood and with a reduced desire. And that can ease during second trimester, and again during third trimester, the problems are different. So what are these various questions which can come in the minds of the couple or the woman? Sex during pregnancy. Is sex during pregnancy safe? When it is not safe? Can sex harm the baby? Can intercourse orgasm cause abortion or uterine contractions? Is sex drive increased or decreased during pregnancy? What is the man's view? So let us look into these questions. Most pregnant women can engage in sexual activity throughout pregnancy in the
Dr. Padmini.
Yes.
Actually, being a gynecologist and sexologist both, I think you can be able to answer this question better than me.
Yeah, so of course.
So over to you now.
Yes. So this is what is that desire, libido, arousal, orgasm vary during the 3 trimesters. So you also know what can happen because of the physical and psychological changes. So especially in the second trimester is comparatively a comfortable period. And again in the third trimester with the increasing size of the abdomen and the imminent delivery. So she will be preoccupied with that and may not be having so much of a desire. So is there any psychological usefulness by having sexual relationships, Sanjay?
Yeah, definitely. One most important thing in sexual relationship is that it's not always the sexual intercourse or penovaginal sexual intercourse which is important. A husband by the side of the bed, touching, caressing with love, affection is also very important. And many times man doesn't understand this because he most of the time is interested in only sexual intercourse. If that is not allowed, then he take the turn and slip by showing the back to her wife. So psychological usefulness of sex is in the overall context of sexuality. It's not only in the context of sexual intercourse. So cuddling, hugging, kissing, all these things are also important so that woman is ensured that she is not looking bad. Husband still loves her. She is not out of shape. So whatever may be her inferiority complex or bad feeling about her overall appearance during the pregnancy period can be taken care of. So husband is the most important person for her. Many times it is said that during labor that women usually curse their husbands why they have made pregnant by the husbands. Many of the stories from the labor wards and in the medical colleges goes on, and that wife during her labor pain shouts at her husband that you are the responsible person for all this pain and all.
We as gynecologists should change this attitude. This is a welcome thing, and it is the pleasure and pain are associated in certain aspects like sexual intercourse, delivery, labor, pregnancy. So if there is a proper mindset, and if you can give this attitude to help them develop a good attitude, not what is shown in the movies or in the serials, like this labor is so painful and it is a rebirth and all the fearful things that is put into the minds of the people should be changed. We should develop a healthy attitude to pregnancy, sexuality, and also the labor. So then the woman can go. That's why many do not want normal labor only, even if they are capable of delivering, because of improper mindset or they are not properly prepared for that. So there are various protective mechanisms during pregnancy which can have the natural protection even if they have intercourse. During pregnancy, the fetus is protected from penetrative thrusting by the amniotic fluid and by the cervix. The thick mucus plug that seals the cervix helps guard against infection. While orgasm may cause mild uterine contractions, even the nipple stimulation and prostaglandin in semen can cause uterine contractions. They are temporary and harmless. And it is also said there are certain immunomodulating substances in the semen which can prevent preeclamptic toxemia, and even the prostaglandins in the semen can help the preparation of cervix for making it soft and ready for delivery. So will sex be different during pregnancy?
Yeah, actually earlier only we had some little discussion that sex during pregnancy may not be just focused as a sexual intercourse, but it is a overall sexuality of the husband and wife. That is very important, because that will be a psychological assurance to the woman and as well as the man also. But many times, like many people say that, that one of our doyen of sexology, Dr. J.V. Bhatt, used to say that which is the most important period for a man to be in extramarital relationship, that is the period of pregnancy, because that is means everybody considers he should not involve himself psychology also, but pleasing each and everyone, not with only sexual intercourse, either mutual masturbation, oral sex, and all these things can be definitely
Yeah.
give sexual pleasure to both the persons, and they will not
Yes.
starve for the sexual pleasure.
Even Masters and Johnson's bankrupt, they all had, it can vary during the 3 trimesters, and the mid trimester can be the comparatively better thing. Will sex harm the baby? This is a very common question both the woman will have and also the husband will have. Usually the baby is well protected. The strong muscles of the uterus and the amniotic fluid will protect the baby. Even when there are uterine contraction, it can move away from the pressure, and also the thick mucus plug will prevent the infections which can happen. So in normally, a baby is well protected inside if there are no contraindications, no genital infections or any problems in the genitalia. So certainly the baby is well protected and not affected by the sexual intercourse. When sex during pregnancy should be avoided. So this
Actually, I will tell you one thing.
Yes.
That whenever the couple comes to us, mostly it's man who comes to us.
Yes.
He said, doctor, when should I do sex during pregnancy?
Yeah, that is the common
So
question.
my advice to him is that kindly contact your obstetrician. So I think you should answer this question better than me.
Yes. So that it is easier to refer the patient to the gynecologist. So many times gynecologist is in a fix whether to ask them to go in for, say, it is to be on the safer side, better advise them abstinence throughout pregnancy. So that can be the attitude of some of the gynecologists. So, but as far as this, when during a normal pregnancy, and if there is no contraindication, sex is not a contraindicated thing. But if there is any high risk pregnancy, toxemia, diabetes, anemia, bleeding, abdominal pains, premature uterine contractions, bad obstetric history, low-lying placenta, all these things I need not tell. All the high-risk pregnancy and high-risk situations, all the gynecologists know. And with the partner, if the partner is having any genital herpes or genital infections, if the lady is having any infection in the genital tract, then that can be the contraindication to have sexual intercourse. Is it normal if there is no sex during pregnancy?
I say no. My frank opinion about this is no, because as already told by many other people also, that can have negative effects on the mind of not only women, but on the man also. So whatever be not deviations, but changes, modifications can be definitely done. And minimum, the touching, caressing, kissing, that is very, very important, because it is said that women is not interested many times in actual peno-vaginal intercourse.
Yes.
But she is more interested in the relationship.
Yes.
And when she is going to her parents' house, that time also husband should visit her. But many times what happens, people only visit the in-laws house after the delivery only. But before that also they should go, so that closeness of the partners or marital partners more specifically is very important.
Cultural things which are there. So as the Australian sexology says, sex is not equal to intercourse.
Yeah.
Sex is more than that. So it is then just to keep the relationship going, they should make some understanding. They should show that they love each other, and with all the other sexual activities which you enumerated, they can keep their thing going. But not having any sexual intercourse really does not cause any problem, because so many times we advise them not to have that, because once they understand the situation and do not have intercourse, then nothing is going to happen. So what is this partners or dad-to-be's behavior? You can tell it better. Reasons for lack of desire for the dad-to-be, or more desire or less desire, and what is his concern?
Basic lack of desire is only because of that convention in mind that if I do sex, it will harm my baby. Because it's not only that mothers, they do care about their babies, but fathers also do, they care about babies.
Yeah.
They may not care about their wives, but they care about their babies more. So that's why their desire can be less. But actually, desire is not less many times, because we are seeing the males, they feel that they should be allowed to have sex. The other part is that women sometimes having pain, some sort of nausea, vomiting early during first trimester of pregnancy, second trimester of pregnancy, she may be responsive or she wants sex. But at that time, because of the long abstinence also, sometimes they start developing some sexual dysfunctions.
Yes.
That not only, but long abstinence of say 9 months to 1 year during pregnancy and delivery, that also make them having some sort of sexual dysfunction like premature ejaculation or sometimes even erectile dysfunction also.
Yes.
My main concern is that husband should be actually involved in the care of his wife and the future baby from the first consultation itself. So he's more involved and he will not have that negative effects and may not have that all extramarital affairs and other things.
The main thing is that you should look into his concerns or answer their questions. That is more important. Is oral sex safe during pregnancy?
Definitely. There is no problem. Only thing is that, as you said, that sexual history, and if the man is having some sort of sexually transmitted diseases, then that is the problematic.
Oh. Only thing is there's kissing, licking and other activities are okay, but blowing of air into the vagina,
Yes.
some people have thought the habit can lead to air embolism. That should be avoided. So coming to an important thing, that is the sexual positions which are most comfortable during pregnancy. Because as the pregnancy progresses with the increasing sizes of the tummy and then the changes in the body, the missionary position may not be comfortable. So you may have to advise them separate positions to have a comfortable sexual intercourse or sexual relationship. What is most important is that they should avoid pressure on the abdomen, avoid deep thrusting or deep pressure inside the vagina. So any position, that is such a woman on top position, she can control the penetration. Side by side position or a spoon position or a doggy position, the woman sitting on the lap of the husband. So these are the positions where there is no deeper penetration, and also it will avoid pressure on the tummy so that it will not disturb her pregnancy or not cause any discomfort or pain to her. So this is very important. You can always advise this and you take and tell her, because in early stage and then up to certain stage of pregnancy, a missionary position can be okay, but there also deeper penetration should be avoided.
Only one suggestion.
Yes.
One addition to that, a woman can be asked to lie down on the edge of the bed, and then man either in sitting or kneeling or standing position can have that sexual intercourse position, so that there is a minimum pressure on the belly of a woman. This is something like this. Can you change this slide, previous slide? Yeah, this is a position, but it is difficult. But rather than doing this, if she is lying on the edge of the bed,
yes, for even the beginners,
and man is perpendicular. Otherwise, sexual position.
Yes.
Yeah.
Dr. Narayan Reddy was explaining that in the previous
yes.
So how the woman can come to the edge of the bed and the man standing, and then so that there is no pressure on both of them, they can control the penetration. Correct. So what are the various sexual dysfunction? Earlier you told because of the long period of abstinence, the man can develop erectile dysfunction, decreased libido, and the woman can have this decreased desire, and also the lack of orgasm or arousal can happen during pregnancy. So there are certain expected or presumed complications during this pregnancy, because many people think whether it will cause any bleeding, postcoital bleeding. So that's why we tell them, because the cervix is soft and sometimes if there are few drops of blood can come. So deeper penetration and thrusting should be avoided. Otherwise, there is no problem. And about prematurity and premature delivery, whether they can have with the sexual intercourse, though this release of the oxytocin and other things with the orgasm, there can be contractions, uterine contractions, but they are not very strong contractions and they pass away. And so it is not that prematurity is increased or preterm delivery is increased in a normal pregnancy when they have intercourse. So this is another thing is about fetal distress, whether there can be fetal distress, because with the orgasm and the contractions, the baby and the increased heart rate of the mother, baby can move around, but still this amniotic fluid and also the strong muscles of the uterus, they protect the baby. So these are not usually there. And about the infections also, unless there is some infection in the genital region, trichomonas, bacterial vaginosis, mycoplasma and other things. So there is no risk of infection or getting the infection getting inside the uterus. So coming to making love after birth. So now that, so you, as you discussed with us in this dialogue, we understood that sex is about the quality of life. We can give them proper advice, make certain changes in their sexual interactions, and also answer their concerns. And as a scientific persons, as gynecologists, should know what is happening in the body. Now, after the delivery, making love after birth. What do you think, Sanjay, we have to do? We have to prepare the woman for all this, to give the advice even during antenatal period itself. So what do you think that when they can make love after birth? And because it's a very important issue. I will give you one or two examples. And I had one patient, after 1 month after delivery, she came with severe pain and then gaping episiotomy. I just asked her what happened, and all slowly she said, doctor, will the intercourse cause this problem? Then I asked, the husband wouldn't listen to her, and they had intercourse after 1 month, and still the episiotomy had not healed properly, and she came with a gaping episiotomy wound. There was another couple who came to me 2 years after delivery. Slowly, the husband hesitantly asked me, doctor, now can we continue with our sexual relationship? So we felt so bad because of the lack of advice to them. And during antenatal period only, the woman and the couple should be, you have to have a dialogue with them and explain everything to them. At the same time, when to resume the sexual intercourse after birth and what they have to observe, what precautions they can take, all that becomes important. Yes, Sanjay, tell me.
Yeah, you are absolutely correct. And in even social custom also, if you see that when a woman goes for the delivery to her parents' house, usually for first 6 weeks, sexual intercourse is not allowed. That is because of all the factors, episiotomy and all. If it's cesarean section, then healing of that wound and that scar also is important. So minimum 6 weeks, 4 to 6 weeks, it is said that sexual intercourse should not be done. And after that, that can be done. But many times the women, they don't allow. So cultural factors are very important. Even a man, if he goes to his in-laws for seeing and meeting his child and wife, he will not be allowed to even sleep in the same bedroom. So these are all things which are very important.
Yeah.
So, and more importantly, nowadays people are feeling that rate of cesarean section has increased. And people feel that because cesarean section is an operation, it's not normal delivery. So what they feel is that they should wait more. People wait for 6 months also. No, my wife has undergone cesarean section, so I'm not doing sex for last 6 months. So these are the histories.
Yes.
So I think that is more important for treating obstetricians to involve them in the dialogue, which we will definitely recommend later on your latter part of our presentation and dialogue. But they should be aware that what they will have to do after the delivery or after the
Yeah, you are very correct. Most of the religions, they have got a custom for after 40 days, 42 days, that is after 6 weeks. That is the normal period of involution, or the genital tract will be coming back to the normalcy. That is the time they make it as a ritual so that the husband and wife can meet and be together. They don't allow them now. Of course, the husbands will be there in the labor room also, and the only husband only will be looking after the wife after delivery also. Things have changed. Otherwise, culturally, they were not allowing, as you said, husband and wife were together alone in the same room. And they were only, my maid servant again, she was going early home every day. I asked her why. Then she said, no, I have to watch them because I should not allow my daughter and son-in-law to have a sexual relationship. So I have to go and sit outside the room. So that was her reply.
Madam,
So that's a natural. Okay, another 5 minutes. 5 minutes only. That's almost the end we are coming. So that is when it is safe to have sex after the birth of the child, and usually after 6 weeks, if everything wounds have healed, and with a good contraception advice and a good lubricant, and telling her if there is any dyspareunia to come back and then contact the doctor. So this is an important advice for all the delivery cases. When you send them home, you can write it also in that, and about the contraception and all that you all know about it. So, but most of the studies indicate that many couples indulge in sexual activity after 3 months, after 3 to 6 months. So after 6 to 8 weeks is most of the studies, if they are comfortable with all the other things, they can have. So there are various reasons for lack of delivery, lack of sexual desire after delivery. You all know that they feel exhausted, lack of sleep, stress, demands of motherhood will be there, and feeling postnatal depression, sometimes it can happen. And the hormones itself, the low level of estrogen itself is one of the reason, and increased prolactin for the decreased desire after delivery. So there are various tips you can give for sex after the birth of the child. So you all almost
I will say only one thing, that before the pregnancy, the husband and wife, they are lovers.
Yes.
But during pregnancy and after delivery, they become parents.
Yes.
And these parents, then they have added responsibility, because we all are parents.
Yes.
A role of parent is till his or her death.
Yes, correct.
Till he or she is alive, he is always a parent.
Yeah.
And that parent responsibility takes role of the lover less important.
Yeah. So
always the lovers should be the main important thing for all these people. Yeah. Maybe sex can be resumed later.
Yes.
But their loving relationship should not end.
The main thing you have to tell them is take care of yourself with the diet, exercise, sleep, rest, and proper food, and also Kegel's exercise, which is very important. So these are all which keeps her fit, and she can come back to her normalcy very soon. There are various studies conducted in different trimester, how the desire can orgasm or the changes occur. These are all the various studies conducted. And also postpartum, during postpartum period also they have conducted how many had coitus, or whether there is low desire or orgasm, all these things have been conducted. So most important thing is ask your doctor, tell them if at all, if there is any problem, either during pregnancy or post-delivery, ask the doctor for sexual queries.
Only one addition.
Yes.
To previous slide. Actually, because we are all here, all doctors, so rather than ask your doctors, our main aim should be tell your patients.
Yes, correct. So in this next to that, side by side, I must write that. Thank you.
No problem.
Yes, more focused research is needed regarding sexuality during pregnancy and childbirth. Most patients welcome the freedom to discuss this topic. Practical advice as a part of prenatal care should be a routine. Thank you very much for the patient hearing. Thank you, Dr. Sanjay, for such a lively and healthy discussion on an important topic, so that can create awareness regarding the topic.
So thank you, Dr. Padmini, and all the office bearers of Karnataka Obstetric Society and South India Sexual Committee, Dr. Mrs. Kamraj also. Thank you very much.
Thank you, sir. Thank you, Padmini Madam. That was a very, very enlightening talk. Now we come to the last panel discussion on vulvodynia. For this, I'm just skipping over all the slides. Ragini Madam is going to moderate this panel on vulvodynia, which is such an important topic as far as every woman is concerned in her life at least once. We have esteemed panelists from all over the country. Dr. Uma Devi from Bangalore, also Dr. Rashmi Patil, also who hails from Bangalore. Tripti, my dear friend from Delhi. She's a wordsmith, has written many non-fiction, fictional novels also. She's a very good favorite. Dr. Preeti Jindal ma'am, also from Chandigarh, and Dr. Poonam Mishra madam from Lucknow. Because of the lack of this thing, I'm just skipping through your CDs, but your CVs are something that we have all seen time and again. So thank you so much. Without much ado, Ragini madam, please take over. Ragini madam, are you there?
Krishna, very good evening to all of
Good
you.
evening, madam.
Thank you, Krishna, my dear. You know how much I like you.
I love you too.
Although we met very rarely, but you're one person whom I ever admire. And my dear friend Jairani, thank you so much for giving me this opportunity. And the topic vulvodynia is something which is really, we don't understand in one word as a gynecologist. Recently, we started talking about it, but I still remember when we are young, a patient was coming that I'm having something jal raha hai, or even I am not able to wear a cloth. We always think that she is a hysteric. So this is a chronic illness, a silent suffering. Let's talk about it. Can you please share the slide from your side? Because I have given to Jairani the whole slides.
Chitrakala, please share the slides.
So all of panelists today, they are all working in the field of the cosmetic and the aesthetic regenerative gynecology. And no doubt the female sexuality is a big discussion in this field. And I'm so honored to share the dais with my, say, mentor, guru, or I don't know how I describe the Padmini madam. She is so knowledgeable. So vulvodynia, if I say it is a chronic vulval pain without an identifiable cause, the location, constancy, and the severity of the pain vary among sufferers. And it can happen to women of all ages. Vulvodynia can become a long-term problem that's very distressing to live with. But much can be done to help relieve the pain. Hope I am audible to all of you.
Yes, madam. Your slides will be on soon.
So, Tripti, my first question is to you, how you will define vulvodynia and what is its etiology?
Madam, Tripti is not there. She's not
Tripti is
feeling
not there.
well.
Anybody else want to take this question?
Yeah, according to the different societies, vulvodynia is any pain in the vulval region which is persisting for more than 3 months. And there could be multiple reasons for vulvodynia. So it's a chronic vulvar pain without an identifiable cause. The location, constancy, and severity of pain may vary in different sufferers.
Okay. So basically, we don't know what is a etiology. Any injury, irritation can cause to the nerves, can lead to a transient pain, an increase in the number and the sensitivity of the nerve fibers in the vulva, or there is elevated levels of the inflammatory substance. Please continue the slides. Sensitivity of the nerve fibers in the vulva and abnormal response to environmental factors. One new thing has come up as a genetic susceptibility. This is something very new, and if research can prove it, then at least we have one etiological cause. Please move the slide. And pelvic floor muscle weakness, spasm, or instability. Please move the slide. Next slide. Next slide. Yes. So prevalence of this is 3% to 7% in reproductive aged women, and only 1.4% of the women seeking medical care were correctly diagnosed. Dr. Patil, please excuse me because it was written Patel, so I have written So it is important to understand anatomy of the vulva and vestibule. What salient features can be taken in consideration when you think of the anatomy of the vulva? Next slide, please. Dr. Rashmi?
Yes. So it's very important that we understand exactly how the anatomy is and at what region she is experiencing the pain. Is it at the entrance? Is it something deep? And how the appearance is? So everything matters a lot, because if there are some infection, if there are some plaques or anything, how it is deviated from the normalcy. So that is very important for us to know. Plus, at what particular region? Is it exactly at the vulval region she is experiencing, or it is somewhere in the vaginal region also? So that is very important to understand the external genitalia, and that includes the mons and the labia majora, minora, the clitoris, and the vaginal area, which is going to be an internal one. So how the nerve distribution, because a lot of factors are there. It could be provoked also, it could be unprovoked. So we have to understand like what is the problem that is leading to this. So understanding a proper anatomy, the nerve supply, how the inflammations are, everything comes into picture.
So the second most important thing when we talk about whenever we think of this vulval area, we have to also think of the pelvic floor muscles, because many a time this pelvic floor muscles spasm, or if they are very, very, what we call as a levator ani syndrome, which is one of the most important DD when we talk about the vulvodynia to the vaginismus also, because it is very difficult for the patient to understand what is vaginismus and what is the vulvodynia. Many a time they come and say they have a difficulty having a sex. So next slide, please. Next slide. Next slide. Dr. Uma Devi, next slide, please. Yeah. What is pathophysiology of the vulvodynia, and what are the types of vulvodynia, and what are the differential diagnosis you will think of a case of the vulvodynia? Next slide, please. Dr. Uma Devi.
Thank you, Dr. Ragini, for this question. As you said earlier, the pathophysiology is multifactorial. And vulvodynia is pain of at least 3 months without a clear identified cause. But there may be some associated factors which could contribute to the pathophysiology of vulvodynia. See, as you rightly mentioned, genetic causes could be there causing the pathophysiology. There may be some genetic polymorphisms that some people respond differently to the candida infection or to any hormonal contraceptive pills, or some response like inflammatory, it may be highly exaggerated in some people. And so they may be experiencing this vulvodynia more frequently than other people. And also they have found that the pathophysiology may be associated with other comorbid conditions, like patients with interstitial cystitis, irritable bowel syndrome, or even temporomandibular pain. They also may be having this vulvodynia symptom. And there could be also like an exaggerated inflammatory response, pathophysiology, like mast cells, degranulated mast cells, or heparinase, and this may be producing highly irritable situation in the vulvar region, and they may be experiencing the vulvodynia. They've also found that some peripheral and central neurological mechanisms causing this. That central neurological mechanisms, there may be some changes in the brain, the structure function, which is different from those people who don't have vulvodynia. And the peripheral, there may be something which is the peripheral nerve endings called nociceptors. They may be having more of these nociceptors, which produce vanilloid receptors, and that may be causing more vulvodynia. So these are some of the pathophysiological mechanisms which can trigger vulvodynia. And now it comes under the new classification as associated factors. But if it is proved, like as you said, genetic, then it will go into vulval pain with the recognized etiology. So that is the pathophysiology. And the second question you had asked about the different types of vulvodynia, the descriptors. The vulvodynia can be generalized or it can be localized. And when it is generalized, it may be throughout whole of the vulva or localized to one area of the vulva, like it could be previously it was called clitorodynia, vestibulodynia, and all those things. So it can be localized or generalized. And that also can be spontaneous or it can be provoked, spontaneous or unprovoked or provoked, or it can be mixed also. Then it can be onset, like it can be primary or secondary. Primary means the first contact. It need not be only genital contact. It can be any insertion of a tampon or insertion of, or just genital contact at the primary onset. It is not, as we mentioned, primary means no idiopathic and secondary means cause, but in vulvodynia, primary means it's the first onset. Secondary means it occurs. Primary, it need not be there. It can come first, if nothing happened, but second contact or third, she may have a vestibular or vulvodynia. That is the onset. Then there is another thing called the temporal pattern. It may be persistent for 3 months, or it can be constantly present, or it can be intermittent, or it can be. So these are some of the other descriptors which has been described in the vulvodynia. The differential diagnosis, my third question. Once vulvodynia is found out, you should rule out other causes. The pain may be due to some reason, like it can be infections, it can be candidiasis, trichomoniasis, or genital herpes, or it can be inflammatory disorders. You can look for lichen sclerosis, lichen planus there, or any contact dermatitis or inflammatory bullous lesions can be found. You look for rule out malignancy, that can be a differential diagnosis. It can be the start of a squamous cell carcinoma or Paget's carcinoma, or some neurological causes like a nerve entrapment syndrome, or it can be a genitofemoral ilioinguinal nerve injury. Then it can be related to a trauma to the vulva. It can be an obstetric trauma like an forceps, or it can be genital cutting, episiotomy, or it can be a trauma to two motor vehicle accidents. Or it can be like in the menopausal age group, it can be genitourinary syndrome of menopause, which can be due to estrogen deficiencies. Then the other iatrogenic causes are, it can be post-operative pain, or pain after the chemotherapy, or pain after the radiotherapy. These are some of the differential diagnoses of vulvar pain.
Okay. Thank you so much. Yeah, excellently you have described each and everything about the vulvodynia. Moving forward, Dr. Poonam Mishra, actually we are very, very late. So very crisply, I want to know what are the salient features in the history and the physical examination of a case of vulvodynia.
Good evening, ma'am. Thank you so much for including me here in the panel. Yes, ma'am, the whole thing has been covered actually. And Madam Uma Madam has covered each and everything. So the history and examination also is directed towards the same in the same direction actually, because the patient comes to us, tells about the pain, the generalized, whether it is generalized, whether it is localized, since when, the complete history we will have to take, whether the patient is having some sort of any incident is there, and the first thing that you told, whether the patient is having vaginismus or some vestibulodynia or some clitorodynia, what kind of pain she is having, it is very difficult for her to tell. We have to actually rule out. So the complete history, any association with any medication or any event with what it had started, and then the examination part comes. We will have to do the complete examination. As you told, we have to be very crisp and very short. We will examine the outer side from the clitoris, the mons area, the clitoris. We go from labia minora to the vestibular area inside. Each and every, we'll do complete mapping actually. So we will pinpoint with a swab. We can do that, whether this is paining, and if there is something, some mental issues are there, with the touch of a swab only, the patient tells that yes, I am having pain over here. You are touching at some other point, and patient tells that the pain is there at some other point. So here also we'll have to rule out whether what kind of this vulvodynia she is having, whether it is something real or something mental or something referred sort of thing. The pain is at some other place and the triggering point is some other point. And then we can go with pin prick also. If nothing is getting out of that examination, we can do some pricking sort of pain. We can elicit that where is the pain and what kind of the pain is there. So from outside going inside throughout the vagina up to the cervix, and in the deeper muscles also, the levator ani, and till what extent we can go, we have to examine. I think, yes, the examination part comes over here.
Yeah. Thank you so much, Dr. Poonam. Please move the slide. So we have to evaluate the patient comorbidity and assessment of the factor. This is the most important thing. So now we have does the history, physical examination, and we have established this is a case of the vulvodynia. So Dr. Preeti, quickly, how you'll manage this case and any role of the laser treatment, because you are a laser expert in your practice. Do you have seen that laser has made a difference in the cases of the vulvodynia?
Yes,
Next
now
slide,
we will
please.
manage this case according to, as all my earlier people have said, depending on what is the cause. Now, if it is a cause because of trauma, we have to identify what was the main reason for her vulvodynia. And without elaborating that, I will move directly to the treatment. We have to treat it according to the cause. If it's because of anxiety, we give anti-anxiolytic. If it is because of trauma or because of estrogen deficiency, we give estrogen replacement, especially in the postmenopausal women and perimenopausal women. And if it is because of the one thing which I have found with the laser is that it is very helpful in the treatment of vulvodynia. If you take IU CO2 laser, and if you take CO2 laser and you just laser the whole vulval area, according to the settings which are given by the company, depending on different laser machines. I have a series of around 8 to 10 patients in which vulvodynia disappeared after 1 or 2 sittings. So laser, and even in few, I have used HIFU as well. So these energy-based devices, they lead to, how do they work? They basically increase the local temperature and they lead to new elastogenesis and collagenesis. They stimulate the nerve fibers in a way that they are not hypersensitive. The new tissue is regenerated and their abnormal pain sensation goes away. Because we see many times women who were having very good sexual relation, they have given birth and still later on they develop vulvodynia. So in such cases, plus in cases who have never had a who are young girls also, outside laser have really helped. So all these new modalities are very helpful. So I have found very good results with them. Yes.
So thank you, Preeti. Any panelists want to add something what we have discussed? So I think we have covered each and every point. Next slide, please. Next slide. Next slide. Next slide. So take-home message from this panel is research on the topic of the vulvodynia is still going on. 25% of the adult Americans suffer from a chronic pain condition. Patients in pain are often neglected and undertreated. This pain condition is severe and debilitating and can be devastating to the patient suffering from it. Scientific level of the evidence for almost all treatment regime is poor, with very few randomized controlled trials have been performed. But I totally agree with the Preeti that laser has really changed this treatment modalities. Next slide, please. Treatment outcomes vary in the studies we have, and the practitioner should be encouraged to take their patients seriously. This is one point I want to really stress, and we should always remember, yes, this condition exists. This is not something in their mind only. Next slide, please. And if you are uncomfortable, you are not thinking in this line, please refer to the patient, refer to this patient to a person who is more in it and have an experience. And this is a high time when we should think upon the referring patient early, not the late. So this is something which is really is there, and we have to treat that patient because their life is really become miserable. And specifically with the discussion of a previous speaker, how important is the sexual intercourse and the sexuality is for the anyone. It can really destroy the whole life. So with this, we have came end to the panel. Thank you so much, Dr. Jairani, although we have done very, very quickly, but I think we are able to give a clear message to the audience who are here and listening this particular panel. And thank you, panelists. You are really make this job very easy. Thank you so much.
With your permission, I would like to just add one thing.
Yes.
Dr. Ragini ma'am is president of Indian Society of Aesthetic and Regenerative Gynecology. Ma'am and myself, we are organizing a very a nice conference in Chandigarh on 29th and 30th of July, and it will cover all the aspects of aesthetic gynecology, infertility, IVF, and we have more than 150 faculty. We invite you all to be part of this conference. It's called Cos Gynae 23, and you must have received the invites for it. Thank you so much, and thank you, ma'am, for making me part of this panel. Thank you, Dr. Jairan.
Thank you, Rajni ma'am. That was amazing. That was, you covered it very crisply and nicely. All the very important practical points. I mean, that is very important. You always want a practical approach, and you have really clearly mentioned everything to know about vulvodynia in the sweetest manner for the difficult issue what a women face. Thank you so much, and a very nice interactions from the panelists, Dr. Preeti, Dr. Umadevi, Dr. Poonam, and Dr. Rashmi. It is so nice of all of you to be here. Very, very good interactions and good discussions and good knowledge sharing. Thank you so much, Rajni ma'am.
Thank you. All the best, Jairani, for your future endeavor. And my vote is for you. My vote is for you because you are working
Tell all your
too
friends
long for it.
Yes, please.
I really wish you very, very best.
Thank you so much, Ragini ma'am, all the panelists. Thank you so much. Now to conclude,
Thank you, ma'am.
Like everyone you meet is either a teacher or a mirror. The whole purpose of education is to turn the mirrors into windows. Thank you so much to all our speakers who turned our mirrors into windows. Thank you so much. Wish you all a very good night. Umadevi madam, that was a very, very crisp everything. I think it was, you kind of handled the whole thing. Thank you so much to all of you. Thank you, Jairani madam, Ragni madam, Ajay Mane sir, I think everybody, Neeraj sir, I think all of you have done a wonderful job. Thank you so much for being part of our seminar. Thank you, and a very good night to all.
Have a nice weekend ahead. Bye.
Thank you.
Thank you, ma'am. Thank you. Very special thanks to Krishna for this nice MC, which takes up most of my, she's so amazingly done everything.
Thank you so much. It's a pleasure to do it.
Lovely. All your words and proverbs are very good. I really enjoyed it, Krishna. Thank you so much. A very special thanks to Chitrakala and Saiti.
Yes, Chitrakala, thank you so much.
Thank you so much, ma'am.
Platform, nice for us. Thank you so much, Sheil, and all the delegates who have been here. Thank you so much.